Thank you, Dr. Pettigrew. And I can say, even though Dr. Pettigrew was gone for most of the beginning of this, he was very involved in the last, and at the 11th hour. Really contributed a lot in the end in refining the comments that I'm going to make. So again, I'm going to be asking our other committee members to come up at the end to help answer some of the questions, especially the tough ones. So you'll be here. But again, this is really an exciting area, and I'm really happy to hear everybody talking about how excited they are about mHealth solutions in this, because many of us have been working in this area for a long period of time. These are pervasive. They touch every corner of the earth via increasingly fine and sensors and systems. They're highly adaptive. This notion of Moore's law, but better, faster, cheaper, is applying to these particular technologies. They're internetworked, meaning that the mobile phone that you carry in your pocket or in your bag is in touch with other databases, other people, other things. This is only increasing and accelerating. The computing power is at multiple levels. It's at the level of the device that you might wear, the phone, and also up in the cloud. Highly customizable. This notion of ever increasingly customization of the experience that people have is very, very important to this initiative. All of this yields new opportunities for those of us engaged in clinical and epidemiological research. And as we report, this leads to new types of science, reduced participant burden, and the opportunity to engage cohorts for a long period of time that we could only dream of a decade ago. This slide depicts cell phone ownership, this notion of the expansion. They are essentially becoming ubiquitous, and this really does cut across all spectra of society and all socioeconomic groups. This is really, really a critical issue. The right-hand side shows that it's not just the phones, it's the entire infrastructure that's existing and that supports this at essentially every level, from hotspots to sensors and other things. And I think this shows the concurrence of this with this notion of the expanded number of people that are sequenced. So we really are at this wonderful moment in history to see this convergence of these technologies. There will be many things that we need to assess in our cohort if we are to accomplish precision medicine. This is a list of a few of them, and we know how poorly self-report performs for each one of these. Vitals and disease-specific monitoring, patient-reported outcomes in real time and in context, medication adherence, cognitive function, physical activity and sleep, geolocation, where do people spend their time, social interactions, diet, smoking and secondhand smoke exposure. Taken together, the current noise in the measurement of these phenomena is just simply unacceptable. We really have to change the game on this, and this is what these new technologies allow us to do. But moreover, as anyone who's conducted longitudinal health research knows, people are people, and they have all of the human characteristics that make it challenging to follow them over time. They move, we lose them, we lose track of them. And infrequent contact can lead to disinterest in participation in studies. So what we have now with mobile technology is a changed game. The emerging ecosystem of wrist-mounted smartwatches, mobile phones, Bluetooth-enabled home-based devices, et cetera, capture a variety of physiological, behavioral, social, and environmental data. In essence, a digital rendering of all of the things that you see there, 24/7. This is really, really powerful. And moreover, bringing these data into the cloud allows for much more sophisticated analyses than might be done on the phone. It also allows us to create research databases in ways that we might not have been able to do before, and to manipulate these in, again, highly creative ways. Smartphone and sensor devices can measure important health correlates and indicators across the entire cohort. Longitudinal passive assessment, again, with no action on part of the user, can be done for many, many things. Physiological parameters, physical activity, sleep. Again, where people go. We need to know this if we're going to understand gene environment exposures. Social interactions, stress, and smoking. And then we can also use the same platform for active assessment of medication adherence or patient-reported outcomes, or audio and video sampling of target questions via mobile media. We're doing this in the context right now with our group in San Diego and MD Anderson Hospital in Houston, using secure mobile video app to capture data from patients in the context of head and neck cancer treatment. A new thing which we're finding highly acceptable on the part of patients, and quite useful to those people who need to document what's going on in the context of that treatment. We're also using it for direct observation of tuberculosis therapy in the US and in Mexico. So, importantly, using disease-specific devices in subgroups can measure very, very important things in specialized subsets. Longitudinal assessment of glucose, heart function through EKG or pacemaker data from those that have them, blood pressure from home-based cuffs, wireless cuffs that transmit into the system, lung function via spirometry, weight and temperature. These are really all things that are quite doable and quite possible. And as Dr. Pettigrew mentioned, incorporating these emerging sensor technologies as they become available, i.e. tattoo or small light wearable sensors, is really a phenomenal area. We have a strong group at our university that's doing some terrific work in this area, and it's mind-blowing in terms of where we are likely to be in 3 to 5 years. So lots of exciting activity in this area. So, as with any technical project, the devil is going to be in the details, and our committee was well aware of this. If mobile is to be a key basis of data collection and engagement for this precision medicine project, special emphasis will need to be given to user interface, user experience, and human-centered design. We cannot get ahead of where our people are with respect to how they use these technologies. Fortunately, the field of human-computer interaction is mature, and there are some terrific scientists working with terrific designers to help optimize how people engage in these. Questions always come up of, will these work in a particular population who don't see well, who have disabilities and have other problems? These are problems some really good people are working on, and again, I'll give you multiple examples of this. So a concerted effort in this will need to focus on that. We will also need to focus on this notion of policies and procedures for mobile data if we're going to have the quality that we need to match the quality of data we have for the biospecimens and the sequence data. That's really, really an important issue, and so I think we cannot overlook how important it will be to quality control this, because we're talking about distributed data collection across a wide variety of individuals in the wild. And that's, again, those of us working in this space know that it's complicated, know that there's a lot of heavy lifting that has to be done. And we sort of envision this cadre of research staff that serve the customers in this cohort as if they are at the Genius Bar at the Apple Store. I mean, we really need to be offering that level of service if we're going to get this level of engagement for these people and not underinvest in this. So if we're successful, we will have an enormous new stockpile of data from which to draw inferences about gene-environment interactions and about causality in disease and response to treatment. We can generate more precise, longitudinally characterized behavioral phenotypes and endophenotypes. We can assess these gene-environment interactions on treatment and health, and better evaluate the impact of adherence on outcomes. Immediate, long-range, short-range, and long-range outcomes can be studied, and we can provide a platform for rapid testing of interventions that will be very, very important. Dr. Kumar is going to be talking about that tomorrow morning. This notion of iterative testing of interventions in a cohort like this is to us one of the most exciting things, because it will allow us to keep up with the pace of development of these mobile technologies, and is really a highly novel dimension of this particular project. Of course, there are lots of challenges, as those of us who conduct research in this domain know well. Standards for these sensor data. We're going to have to come to terms with this. How will we do this and address these across the variety of populations that we're studying and across the types of devices that are capturing those data? We know the more raw the data is, the better, but many of the companies that are capturing these data are not willing to provide that. They're only willing to provide certain types. Privacy, security, and verification. This has come up before. How do you know the person providing that information at the other end of that technology is the person that you actually want the information from? The notion of motivating people with social, financial, and other incentives is really going to be an important thing, and this was touched on by previous speakers. Social networks, behavioral economics, other kinds of things, really, really important to continue to engage them. The social cultural acceptance of this. Again, this cohort, a broad cohort, can include nested subgroups of populations that many of us are really, really very interested in studying, and we have this ability to do through both quantitative assessments and mixed method strategies, actually understand how people are adapting and benefiting from participation in this. Data quality in the wild, again, another thing that we deal with a lot, this whole notion that there's lots of noise out there. How do you extract the signal from these data, and how can we ensure that we are, again, optimizing what we're learning? I spoke about this notion of ease of use for people with very technology backgrounds, et cetera. Connectivity and bandwidth. We all know the problems that we experience with that when we travel. I mean, this notion of if this is going to be done in a way that's representative of everyone, we have to have the ability to have connectivity and access across the U.S. We can't leave rural people out. We can't leave people in certain areas of the country that might not have that. This whole notion of the technical interface of the sensors with various digital platforms. Again, it's a wild west out there in many respects in terms of these. Dealing with this is a non-trivial matter. And again, those of us working in this space, rolling up our sleeves, trying to sort these problems out, but these continue to change. And so keeping up with this is important. as I mentioned, the rapid proliferation of technologies, and ownership of data. We touched on this a little bit, ownership, rights to use, whatnot. The companies that capture most of these data actually own the data. The terms of use that are used for this say that the company owns the data. How can we, as an initiative, ensure that we have full and free access to these data for our research? So finally, before we get into the question section, our audacious ideas, really two. One, imagine if we could recruit volunteers to open up all of their data. Again, not the entire cohort, but people to open up all of their genomic data, their microbiomic data, medical EMR, behavioral, social, precise geospatial data, so that multiple influences between and among these influences on health can actually be understood. Arguably, mobile and wireless technologies are the only thing that allow us to help connect the dots between these as this living, breathing system moves forward. And so this notion of having data at all of these levels over time will be a really, really critical thing. And so finding locations where we can do this might be critical. And then we talked a little bit about this notion of culture or motivated participatory research. What if we were able to get a few communities around the country that were densely populated with members of this cohort? So not only do we get the EMR data and the mobile data, but we also can geospatially characterize them in that particular community, and we understand. So this is sort of the Framingham 2.0. It's this notion that place matters, health happens where you live, and if we could get a few communities to sort of be leading edge communities and to be known for this, this could potentially be an exciting dimension of this project. So with that, I will close on the overview of our white paper. I'd like to invite our committee members to come up. We'll move around the microphone here because we'd like to leverage your expertise on the answers to the questions. So.